Heidi.
Thank you. This is just going to be a brief overview of iron deficiency anemia, looking at kind of where we start from and going from there. With iron deficiency anemia, it is the most common anemia worldwide, affecting over 1 billion of people. Workup needs to be completed to find the reason for iron deficiency, but a reason isn't always found. They approximate about 10% of people. We never find a clear cause of why they have a low iron level. So, looking at the causes of iron deficiency anemia, I think the number one cause that always comes to mind is certainly from blood loss, whether it's from heavy periods through GI blood loss, surgery, childbirth. One of the things I never thought a lot about until I had a situation with it is blood donation. If people are routinely donating blood or have excessive phlebotomy, you definitely can see that with blood loss. Hematuria is another reason for blood loss. But if you're not finding anything in the history in relation to blood loss, then other reasons are just poor intestinal iron absorption or not taking in a lot of iron. So some of those things would be like a vegetarian diet. A lot of our people that are sent to us for iron deficiency have been those that have had some sort of gastric bypass surgery. Other reasons could just be a chronic PPI use, celiac disease, H. pylori, gastroparesis, definitely can lead to iron deficiency anemia. And then the other reason would be is if there's just an increased need or increased utilization of the iron, as we see in pregnancy, rapid growth, or just recovery from the anemia itself or erythropoietin stimulating agent use. So some of the common symptoms that you may see are fatigue is probably the number one symptom that people will complain about. Oftentimes they'll have a craving of ice. I've heard a lot of stories where they're out buying bags of ice or they just went and bought an ice machine so they can have ice regularly available to them. So that's a big one as well. Other ones include restless legs, changes in the nails. Certainly if they're very anemic, they're going to have some heart palpitations and shortness of breath. Cold intolerance, weakness, headaches. If they're anemic, they're going to look pale, and the glossitis. So one of the things I think is probably the most important thing when you're looking at iron deficiency anemia is to try to figure out the why portion of the equation. So when you're going through the history, just be sure to ask them about any GI symptoms that they may be having, whether it's a change in their stool, in the consistency or the color of it. They're having abdominal bloating, much reflux, or intolerances to foods. Go over their social history to see if there's a big smoking history. If there is, you could always consider to do a UA to check for hematuria. Family history is going to be important, especially if you're looking at a colon cancer history in the family. Anemia sometimes runs in the family itself or any autoimmune diseases. Surgical history are going to hone in on the gastric surgery, especially if they've had any type of weight loss surgery. And I always try to check to see if they've had a colonoscopy or an EGD done in the past. It's good to review their medications, looking for any PPI use or anything that they may take at home that they aren't listing as a regular medication for them. And then in the females, I usually do a menstruation history just to kind of get an idea of how much blood loss they do go through. And then going on after you do the history, of course, the first thing you're going to do is look at a CBC because you want to be checking to see if they certainly are anemic, which would be defined of showing a low hemoglobin with a hematocrit. Oftentimes they will be microcytic and hypochromic with a low MCV and an MCHC. And then oftentimes their RDW, their red cell distribution width, will be elevated. One thing to consider if you're looking at an anemia and it's normocytic, it's not microcytic, then you might want to consider checking a vitamin B12 and a folate level as well. And continuing on looking for laboratory workup, reticulocyte count is good to do as it will give you the retic hemoglobin, and below 26 indicates an iron deficiency. If you look at the assay here where we are at, oftentimes normal will be at 28. And then, of course, you're going to look at a whole iron panel, and then you would need to order an iron panel and then a ferritin. The ferritin's not included in the iron panel. So when you're looking at the iron panel itself, it'll show a lower ferritin and an iron saturation are usually low. And then the TIBC and transferrin will appear normal to high. Other testing that I would typically recommend is doing an H. pylori testing, just so that you're not missing that portion of, is it an absorption issue from H. pylori? Plus, especially if it does come back positive, you're going to want to be sending them to GI. You'll want to go ahead and treat the H. pylori testing, make sure it returns negative, but you don't know how long that infection has been there. So it's always good to send them to GI so they can have a follow-up EGD at some point. Then a Gims saying just to take a better look at the blood cells. Celiac testing, if they have a lot of abdominal bloating or they have some food intolerances, then I'll typically do some celiac testing. And then again, if they have a big smoking history, then I would, you can consider doing a UA as well. So this is just showing this came from Up to Date, and it's just kind of showing when you're looking at the CBC and the iron studies, exactly what category does it fall into? Because you can have iron deficiency occurring, but you may not be anemic with it. So of course, if you have that going on, your hemoglobin, your hematocrit are going to look normal, but the ferritin still may be on the lower range. So they are including this to be a ferritin of less than 40. Your serum iron, maybe 60 to 150. So you just look down through there to see that, because you can have the iron deficiency without the anemia. And then they categorize it looking at iron deficiency with mild anemia and iron deficiency with severe anemia. Of course, the more severe it is, your hemoglobin is going to be lower. So they consider that with a hemoglobin of 6 to 7. Your TIBC is going to be greater than 410. Your ferritin is going to be less than 10. And then it says no data available on the retic hemoglobin. And the only thing I wanted to mention about that is on the mild iron deficiency with mild anemia, it shows a retic hemoglobin of 14 to 34. On ours here that we run, it'll just say a retic hemoglobin of less than 20. So you know it's a very low retic hemoglobin, but that's the lowest that we can see on those studies. And so this just kind of puts you categorically looking at the labs overall, where you're at with the anemia and with the iron deficiency. And this is just a neat little picture that I put in here again from Up to Date, showing if you did a Gims stain. So the one on the left-hand side shows your red blood cells looking normal. It's also showing some lymphocytes on there. And then when you get into iron deficiency anemia, your red blood cells are more irregular looking. They look smaller, they look more pale, and sometimes they can appear pencil-shaped as well. So, of course, typically what you want to do if you're seeing an iron deficiency, and oftentimes this has already been done by their family practice provider, is to do some sort of an oral iron therapy. So these fall into iron sulfate, iron gluconate, and iron fumarate. And I usually have a tendency to go towards the iron gluconate just because it's usually better tolerated GI wise. And I usually would do a Monday, Wednesday, Friday dosing or an every other day dosing. It's just easier on the GI tract because that's going to be the biggest complaint. And the biggest thing that keeps people from wanting to take it is because of the side effects. So the every other day seem to be better tolerated. The problems if you're trying to get away from some of those side effects, people will want to do the enteric coated, and then it seems to be released too far down in the GI tract to really get a good absorption of it because it's mainly going to be absorbed in the duodenum. And then, of course, the other things that people typically will say is they feel nauseated with taking it and they will have constipation. And so you can try to have them taking it at night just to see if that helps with those side effects. And of course, they can take a stool softener if they're having some constipation. Some other considerations if you are talking to somebody about wanting to take an iron supplement is again looking at their medication list. So if you see somebody that's taking Prilosec or Pepcid every morning, then try to have them take that iron in the evening because that is going to inhibit the absorption of the iron if they're taking them concurrently. Other things that could cause problems with the absorption is if they are taking supplements with zinc or copper, calcium, and then some beverages like coffee, milk, or if they're taking it with a lot of fiber. So the vitamin C can help with the absorption. The problem if you're taking it with like a multivitamin that may have zinc and calcium in it is that these two elements have a tendency to compete for the absorption in the small intestine with the iron. So that is the reason you want to kind of separate all of that out. And just a thought here also is the rate of iron absorption becomes slower once the patient is no longer anemic. So initially, when you're starting an oral iron, they're going to show more absorption at that time. The goal is to reach a ferritin level of at least 40 before stopping an oral iron supplement, but this can often take up to 3 to 6 months. And as we talked before, the recommended dosing would be to take it every other day for better tolerability. So if you have done the oral iron formulation and you're not getting to where you need to be, or if they've already tried that before you're seeing them, then we can move on to IV iron. And there are several IV iron formulations. All the ones that I'm going to discuss currently, we do here in Morgantown. But I think it is a lot of variability across the board, what's available at different institutions. So Fairlacet is one that I've seen that is given more frequently, probably inpatient. I don't see it outpatient very often. And it comes in a dosing of 125 over 30 minutes or 250 over 60 minutes. The other one is iron sucrose, which is Vinifer. Two different dosings that we give here is 200 milligrams over 30 minutes. Oftentimes, if you put it in a supportive plan, it'll come up 200 milligrams and it'll come up 5 doses. When you are prescribing that, you can do it actually 3 doses in a week. You can do like a Monday, Wednesday, and Friday at the most, and then 2 days the following week. If you do the 300 milligrams, when you put in the plan, it's going to come up that for the 3 dosing. And when you put that in, it's going to come up that you need to give that once a week for the 3 doses. Vinifer is one of them I feel like that we give pretty frequently. And one of the reasons is if you go to put your iron formulation into the insurance company and they wanted to deny it, they'll be like, we'll let you give an iron infusion. Their go-tos that they often will cover are Vinifer and Infed. Those are the 2 that they'll usually say will definitely cover. The third one that I'm going to talk about is Ferriheme. So when you put in a plan for Ferriheme, it's going to come up with 2 doses in the supportive plan for it. It can be given over 15 minutes, and when you open up the plan, it's going to show that it's going to infuse over 15 minutes. But I always feel like with the Ferraheme, just in my personal experience, that 15 minutes, they don't do well with it. They just don't feel good with it. So I always put it over 30 minutes, and people seem to have much better tolerance to that. One of the things that I did learn while I was putting this presentation together, I had no idea about this, was that with the Ferraheme, it says it can cause a brighter signal on MRI scans. So I guess this is important to be aware, but it doesn't negatively affect the interpretation, but it does look brighter. So they just recommend that if somebody is scheduled to have an MRI, for them to mention it to the provider who's ordering it, or to the radiology provider, that they had a Ferraheme within 3 months of getting their MRI done. So the other three ones are Injectifer. Again, if you put in that plan, it's going to come up with two infusions for that. It's 750 milligrams over 15 to 20 minutes, usually 2 doses, 1 week apart. One of the things that I have learned with the Injectifer, it does have a very high rate of causing low phosphorus levels. So it is one of those drugs that if you give, you really should be checking a baseline phosphorus just to see if they're already on the lower side. I would probably steer away from that. If they do not have any history of a low phosphorus level and their labs look okay, then you could give it and repeat your phosphorus level before your next infusion, and then definitely repeat it when you're seeing them on follow-up, checking a phosphorus level. I had not seen this routinely being done, and then I started to see that a little bit more and learned a lot from that from a patient. So the other one is NFED. NFED is a longer infusion. So when you're first ordering NFED, it'll ask for a test dose of 25 milligrams that's given over an hour, followed by the 975 milligrams over 4 hours. If they do well with that, you give them another dosing of 1,000 milligrams down the road. You do not need to repeat the test dose and can just go with the 1,000 milligrams over 4 hours. Finally, the other one that is newer to the market is monoferric. It's a single dose of 1,000 milligrams or up to 3 doses of 500 given over 7 days. I've only seen the 1,000 milligram dosing here. It's a 20-minute infusion. And anybody that I have seen on follow-up after getting the monoferric have done really, really good. So I was happy to see it because it gives you that dosing and it's pretty quick and they're not here all day. And from what I've seen so far, people have done very well with it. I'm trying to get my slide to go. Here we go. So some of the most common side effects you can see when you are giving the iron is that you can cause some hypotension, some nausea, some vomiting. They'll complain of some abdominal discomfort, abdominal bloating. Serious reactions can also occur that we're well aware of. These are more rare, but you do need to discuss with the patients when you're ordering the IV iron that you can get into a reaction and a severe reaction with an anaphylactic reaction. I had done I did not do it myself. I had looked up this study done by the U.S. Food and Drug Administration. It was an adverse event reporting, just looking at the frequency associated or anaphylaxis hypersensitivity associated with different iron infusions. So what this showed basically was the lowest rate of reactions occurred with the Injectifer, followed by iron sucrose or the Vinifer, and then the highest reactions were seen with Ferraheme and with NFED. And I believe, as Brenda had talked about this previously, Um, Whenever people are in a reaction with the iron, you never give them Benadryl. The Benadryl can cause them to be more hypotensive, so you never give Benadryl. One of the other things to consider is if I see somebody back or I get called down to infusion to see somebody and they said, I did okay with the first one, but then I got really nauseated or had any issues with it at all. Oftentimes I may give them a little bit of Pepcid before I start. I'll give Zofran if they're having nausea. And the other thing to allow better tolerability with iron is just slow the infusion down itself. So if they did okay, but not feeling the greatest, and if let's say it's a vinifer infusion, you might want to consider giving that over an hour versus 30 minutes because slowing it down is going to give you, has always given me the best success rate with trying to get people through iron infusions. So other considerations, pre-medications are not typically given with the iron infusions. Like I said, you just base it on what the patients are telling you when they come back in to see you. Slowing the iron down to help with tolerability. The other thing is that if anybody has an active infection going on, you're going to want to hold off giving your iron infusion until they are over an active infection. And then, as I said before, never give Benadryl as a pre-med or during a reaction. So follow-up and monitoring, it said when I was looking at up to date that for patients receiving an oral iron supplement, you can consider follow-up in 2 to 4 weeks after starting it. And at that time, you can just basically check a CBC and a retic count just to see where they're at. If they're having the anemia, the hemoglobin should start to rise by at least 1 gram in 2 to 4 weeks. For IV iron, it's important to wait at least 4 weeks to 8 weeks before bringing somebody in to check their CBC and their iron numbers. If you do it before that time, then your iron levels are going to be all wonky. It's going to look like you overdosed them in iron. If you wait before that 4-week period, it really messes up the picture there. So just a few cases to go through about some iron deficiency anemia. So this one included a 45-year-old female who came into clinic complaining of iron deficiency anemia. She did have a history of chronic constipation, tachycardia, asthma, anemia. She had been on oral iron for over a year, but really had a hard time tolerating it because of constipation. Her main complaints were fatigue, achy bones, headache, shortness of breath, pica, bruising easily, and bleeding gums. She had a history of endometriosis, and so she was having very heavy periods lasting 7 days, needing to change a product every 2 hours for the first 3 days. So we were able to look back through the system, she came to see me in 2019. In 2013, her ferritin had been 3. Her TIBC was elevated at 466, hemoglobin 11.2, MCV was 77. 6 years later, and after being on oral iron for a year, her ferritin was 5. Her iron binding capacity was higher at 567. Hemoglobin had dropped to 9.2, and also she happened to have a B12 level of 285. She had already had an EGD, which showed normal villus architecture, so that ruled out having any type of celiac picture. And then she had a colonoscopy in which a polyp was removed, showing a tubular adenoma. She had no alcohol history. She was a former smoker, and her family history was significant for ovarian, anal, colon, and lung cancers. So she was ordered Injectafer, 750 milligrams times 2. First infusion went okay. When she came in for the second infusion, she was found to have an elevated blood pressure and reported a headache for 2 days. The Injectafer was held. I checked her phosphorus level and it returned at 1.1. So normal is 2.4 to 4.7. So she was given IV replacement of phosphorus. rechecked her phosphorus level 10 days later, and she was 1.1 again. She got 10 days of KPhos. She came back in October of 2019. Her phosphorus was 1.7. We went ahead and treated her with KPhos again for 7 days. She did show an improvement with her hemoglobin with just the one iron infusion to 12.2, and her ferritin was 47. So she ended up dropping her numbers again in December. And so she was given Ferraheme 510 milligrams times one dose. And then you can see she returned. She wasn't anemic on these return labs. Her iron levels had improved. And eventually she ended up with a hysterectomy, which took away that bleeding aspect that was causing her iron deficiency, and she did not need further iron down the road. But this is just one of those scenarios that I wanted to show about how your phosphorus can go very low with some of the iron formulations, especially with Injectafer. This second case is a 46-year-old male who came in for iron deficiency anemia from his PCB. He had a history of IBS, a bleeding ulcer, and hyperlipidemia. He reported that he was having a fluctuation between diarrhea and constipation. Stools were appearing darker, sharp pain to right upper quadrant. He had a craving for pork rinds, shortness of breath, dizziness, fatigue, and restless legs. No significant family history or smoking history. Did have an alcohol history, but he had quit drinking in 2008. So again, this is a 46-year-old. You're looking at IBS, which would show the fluctuation between the diarrhea and the constipation, but it was so concerning because his ferritin was less than 1, so he would be considered severely iron deficient. His hemoglobin was 9.5, his iron binding capacity was 456, and his MCV was 64. So this certainly is an unusual presentation for a 46-year-old male patient. I ordered him Ferraheme. I ordered a stat EGD and colo, and the EGD showed non-erosive gastritis, and the colonoscopy showed a 3-centimeter fungating mass. So this ended up showing well-differentiated adenocarcinoma, and he had a right colectomy. Fortunately, he was staged at a stage 2. He did not have any high-risk features. He did not need chemotherapy, and he currently follows at UHC Oncology for continued surveillance. So I just threw that one in there because these are the little things when we are thinking about iron deficiency, and it's so common with people, but you don't want to miss the things that we're seeing. And then this is just a case of chronic iron deficiency. This is a 72-year-old who had a history of Barrett's esophagus, GERD, hypertension. She's on CPAP for sleep apnea, vitamin D deficiency. She had a history of a blood transfusion in 2008 when her hemoglobin was 6.9, and at that time she was found to have a GI bleed. She had been on iron for 2 to 3 years, taking it twice a day. Family history of colon cancer. So she had had several colonoscopies in the past. She did end up with a capsule endoscopy, which showed some AVMs. And looking back through her lab, she consistently had an iron deficiency anemia dating back to 2010. So I had seen her, she had received some iron infusions, then she got lost to follow up and returned back in. These are all the times that she's been receiving iron infusions, so several of them. She did go back in for an EGD in 2022 because I felt like she just needed to be checked again. And she had a 10-centimeter hiatal hernia with 2 small erosions in the duodenal bulb. So these Cameron lesions in the hiatal hernia, and 4 AVMs in the duodenum. So these are all areas that she can easily bleed from time to time. She's been seen by thoracic surgery. She refuses to have surgery to have any of this repaired, and so she will likely be somebody that needs IV iron for the rest of her life until she would decide to get that repaired. I wanted just to mention briefly when we think about iron deficiency, and oftentimes we see a microcytic anemia picture with that. And I could not find the notes that I wanted to reference to because it's been quite a while since I had this case, but there was a young African American female who came in with pregnancy for iron deficiency anemia, and she had the clear picture of what you would typically see, but she was just so microcytic. And her OB provider had done a hemoglobin electrophoresis on her, which had some abnormalities on it. But in reviewing everything, you really can't, in the hemoglobin electrophoresis, you really need to replace the iron with somebody that's also iron deficient before the hemoglobin electrophoresis can really be show its true picture of what's going on. So after she was finally replenished with the iron, her iron levels were looking normal. She still showed a low retic hemoglobin. She was still very microcytic. We repeated the hemoglobin electrophoresis, and she does have a type of thalassemia. So that's another thing just to think about, that if you're recovering your iron levels, you still look like you're microcytic, you always need to think about doing a hemoglobin electrophoresis on those people and then sending them on to somebody else to take care of that. These are just some of the references that I have, and that is all I've got, unless anybody has any questions.
Right. Are there any questions for Heidi? Give you all a second. Please feel free to type them in the chat, or you can chime in on with your voice. Alrighty. Well, thank you all for joining us today. I appreciate it. Like I said at the beginning, we will be sending out the recording at the end of this in the morning. So if you need anything before then, please feel free to reach out. Alrighty. If there's no other questions, we'll be happy to see you guys again in August on the 28th.